Supportive care and symptom control during pancreatic cancer treatment. Hello, this evidence-based content is prepared by Saboor fellowship-trained consultant surgeon, and if you or someone you care about is facing pancreatic cancer treatment, you're in the right place. I know hearing the diagnosis and starting treatment can feel overwhelming. The symptoms, the side effects, and the uncertainty about what lies ahead. But here's what I want you to understand. While we fight the cancer with treatment, we have powerful tools to manage symptoms and maintain your quality of life throughout this journey. Today we're going to talk about the specific supportive care measures that can make a real difference during pancreatic cancer treatment. By the end, you'll understand what symptoms to expect, how they can be managed effectively, and most importantly, you'll know exactly when to reach out for help and what questions to ask your medical team. Supportive care, also called palliative care, is specialized medical care focused on relieving suffering and improving quality of life for anyone facing serious illness like pancreatic cancer. Now, I need to be clear about something that many people misunderstand. Palliative care isn't just for end-of-life situations. It's designed to work alongside your cancer treatment from the very beginning. Think of it as an extra layer of support that addresses pain, manages symptoms, helps with communication about your goals, and coordinates your care across different settings. Research demonstrates that when palliative care starts early in pancreatic cancer treatment, it improves not only your quality of life, but may also extend survival. Studies show it reduces unnecessary emergency room visits, decreases ICU admissions, and helps patients avoid aggressive treatments near the end of life when they're unlikely to help. Pain is often the major presenting symptom in pancreatic cancer, and all patients should have pain addressed at every clinic visit. You're likely experiencing a gnawing pain in your upper abdomen that radiates under your ribs and into your mid-back. This happens because pancreatic tumors sit very close to a nerve bundle called the celiac plexus. The mainstay of pain management is opioid medication, medicines like morphine or oxycodone. If you're worried about taking these medications, let me reassure you. When used appropriately for cancer pain, they provide essential relief and allow you to maintain function and quality of life. For patients struggling with nausea who can't take pills, transdermal patches can deliver pain medication through the skin. But here's where it gets interesting. Because the tumor affects those nerves, I mentioned the pain may be neuropathic, nerve pain that feels different from regular pain. This warrants adding medications like gabapentin, pregabalin, nortriptyline, or duloxetine alongside your opioids. These adjuvant medications specifically target nerve pain and can significantly improve relief. There's also a specialized procedure called celiac plexus neurolysis, or CPN, that can provide remarkable pain control. Research shows that early CPN provides better pain relief, less opioid consumption, and better quality of life compared with waiting until pain medications fail. This involves injecting medication directly into those nerve bundles to block pain signals. Where local expertise is available, this is often preferred because relief from pain happens faster than with other approaches like radiation therapy. Cancer-related cachexia, which means accelerated loss of skeletal muscle with chronic inflammation, occurs in up to 80% of pancreatic cancer patients, particularly those with metastatic disease. Now, what does this actually mean for you? You're not just losing weight, you're losing muscle mass even when you're trying to eat. Your body's resting energy expenditure is inappropriately accelerated. You have reduced appetite, and your nutrient metabolism is altered with increased protein breakdown. All patients with advanced pancreatic cancer should consult with a nutritionist or dietitian if this service is available. Here's your practical guidance. Dietary intake should be assessed along with the possible need for dietary supplements. The evidence shows frequent small meals work better than large ones, and you should avoid foods that are difficult to digest like legumes. Importantly, and this surprises many people, severe fat restriction is no longer recommended. Your body actually needs some dietary fat, especially to absorb fat-soluble vitamins. Here's something that affects 64 to 100% of pancreatic cancer patients, but often goes unrecognized: pancreatic exocrine insufficiency. This means your pancreas isn't producing enough digestive enzymes, leading to maldigestion, fat malabsorption, and steatorrhea, fatty greasy stools. The main clinical manifestation is weight loss, but you might also experience abdominal cramping, flatulence, and urgency to defecate. We suggest that patients suspected of having fat malabsorption be treated empirically with oral pancreatic enzyme replacement therapy. You don't need diagnostic testing first. If you have the symptoms, we start treatment. The standard dose is 30,000 international units of pancreatic lipase with each full meal, and half that dose with snacks. Here's the critical part about timing. You should take enzyme supplements at the start, middle, and near the end of each meal. Patient compliance is key. If you don't take them consistently, they won't work. These preparations are often microencapsulated and acid-resistant to survive stomach acid and release in your small intestine where they're needed. Unrelieved jaundice from an obstructed biliary tree causes intense itching and increases infection risk. Palliation of jaundice is usually accomplished by placing an expandable metal stent, a small tube that holds the bile duct open. This is typically done endoscopically without major surgery. For gastric outlet obstruction, when the tumor blocks food from leaving your stomach, you might experience severe nausea and vomiting. Gastrostomy or jejunostomy tubes can both relieve symptoms and provide an opportunity for nutritional support during active therapy. For patients who cannot eat because of delayed gastric emptying, but are otherwise candidates for chemotherapy, this feeding tube approach is preferred over total parenteral nutrition because it uses your functional intestinal tract and avoids infection risks. The diagnosis of cancer is unsettling to anyone, and knowing the aggressive nature of pancreatic cancer may lead to depression, anxiety, and adjustment disorders. Here's a striking statistic. A systematic review of 71 studies found that depressive symptoms occurred as a prodrome, meaning before diagnosis, in approximately 38 to 45% of patients newly diagnosed with pancreatic cancer. Anxiety was observed in approximately 12%. All patients can benefit from discussion of psychosocial concerns and available support systems. Some patients benefit from cancer support groups through organizations like the American Cancer Society. Others may need treatment with antidepressants or anxiolytics, and others need ongoing formal support from a social worker or psychiatrist. If you're supporting someone through this, encouraging them to voice these concerns and seeking professional help is as important as managing physical symptoms. Pancreatic cancer is associated with high risk for venous thromboembolism, VTE, which includes deep vein thrombosis and pulmonary embolism. In patients with pancreatic cancer, the incidence of VTE is 4 to 7 times higher than those with other cancers. The risk is highest in the first 3 months after diagnosis, and chemotherapy further increases this risk. All patients should be educated about warning signs and symptoms of VTE. That means knowing to report sudden leg swelling, chest pain, or shortness of breath immediately. If VTE occurs, treatment typically involves anticoagulation, blood thinners, but the decision can be complex because of bleeding risks and drug interactions with chemotherapy agents like fluorouracil. First, advocate for early palliative care consultation. Don't wait until symptoms are severe. Request this at your next oncology appointment. The evidence is clear that early involvement improves outcomes. Second, establish pain control expectations. Your pain should be assessed at every clinic visit. If your current regimen isn't providing adequate relief, speak up. Ask specifically about celiac plexus neurolysis if you're experiencing severe constant pain. Third, schedule a nutritionist consultation. Rather than 3 large meals, try 5 to 6 smaller ones throughout the day. Don't severely restrict fat. Your body needs it for vitamin absorption. Avoid hard-to-digest foods like legumes, but maintain adequate caloric intake. Take your pancreatic enzymes correctly if prescribed. This means at the start, middle, and end of each meal. Compliance determines effectiveness. Don't skip doses. Should I be referred to palliative care services now, even though I'm still receiving active treatment? What is our plan for pain management if my current medications aren't providing adequate relief? Should we consider celiac plexus neurolysis or additional adjuvant medications for nerve pain? Do I need pancreatic enzyme replacement therapy? What symptoms would indicate I need this? What are the warning signs of blood clots I should watch for? And what's my personal risk level? Are there mental health resources or support groups available for patients and families dealing with pancreatic cancer? If I develop jaundice or vomiting, what's the threshold for intervention like stent placement or feeding tube? Contact your healthcare team immediately if you experience sudden onset of leg swelling, especially if one-sided, or chest pain with shortness of breath. These are VTE warning signs. Severe uncontrolled pain despite medication. Don't wait for your next scheduled appointment. Persistent vomiting preventing you from taking oral medications or fluids. New or worsening jaundice with yellowing of eyes or skin, especially with fever, which could indicate infection. Mental health crisis. Severe depression, anxiety, or thoughts of self-harm require immediate psychiatric evaluation. Supportive care during pancreatic cancer treatment isn't optional. It's essential medicine that works alongside your cancer therapy to maintain quality of life and may extend survival. Your next step. Request a palliative care consultation at your next oncology appointment and advocate for comprehensive symptom management, including pain control, nutritional support, and psychological care. This information is for education. Always discuss your individual situation with your healthcare provider. I've outlined several reputable resources here which you may find valuable for further information on this topic. Up-to-date Medical Reference provides comprehensive, evidence-based information on supportive care for pancreatic cancer. American Cancer Society offers patient support groups and educational resources for pancreatic cancer patients and families. American Society of Clinical Oncology has clinical practice guidelines on pancreatic cancer care and palliative services. National Comprehensive Cancer Network provides guidelines for symptom management and supportive care during cancer treatment. European Society for Medical Oncology offers international guidelines on pancreatic cancer supportive care. All links are available in the description below. Thank you for watching.